Einthoven's contribution to the field of medicine was huge, and we all owe him a debt of gratitude. We can see him pictured here with one of his early machines, and notice his hands and feet are immersed in a salt water bath. These days we use a conductive electrode gel instead of the salt water baths. And these are the electrodes that pick up the electrical activity of the heart through the skin. Now last semester we learned that the skin conducts electrical current, and this was demonstrated through our chick experiment. If you'd like a repeat of that demonstration, just let me know. I'll have the chick with me in class. This video is an introduction to EKGs to get you started with the basics. Some of you will be learning more about the analysis and interpretation of these things in the future. For now, we will stick to the introductory material. Before we look at the Ecg tracing, it is important to understand exactly what you're looking at. So let's learn first about the graph that is used to do the analysis and take the measurements on the tracings. A typical ECG grid shows a group of smaller boxes within a larger box, and each large box is 0.2 seconds long and 5 millimeters high. If we looked at this grid as a graph, time is measured on the x-axis and amplitude is measured on the y-axis. When we refer to time, we talk about duration, and when we refer to amplitude, we talk about magnitude. These two measurements give us information on how long and how much, and the how much is usually measured in millivolts. The Ecg tracing is the sum of all of the electrical activity in the heart. Essentially, we are viewing all of the action potentials of all of the cardiac cells, whether they are conductive cells or contractile cells. The larger the number of cells involved, the higher the amplitude of the wave. So keep these things in mind when we start to look at these ECG tracings. Before we begin analyzing the ECG tracings, let's look at one of the most commonly used setups for electrode placement. This is the lead 2 electrode setup. This will be the electrode setup that we use in lab. So we have 3 electrodes. Only 2 are shown here because the third one is a ground. Now the positive electrode is usually placed on the inner aspect of the left ankle. The negative electrode is placed on the right wrist, and the ground is usually placed on the inner part of the right ankle. You might notice the large arrow in this person's chest with a negative and a positive pole. What this is showing is the average direction of the wave of ventricular depolarization. Also notice the electrode placement is almost perfectly parallel to the direction of depolarization. A lead that runs parallel to the line of movement of the electrical activity will give us the largest deflections. And so for the majority of people, lead 2 will be the most closely parallel running lead to the line of ventricular depolarization. And it's why it's the most often referenced lead. By the way, the arrow represents the mean electrical axis of ventricular dipole. These strips are showing a typical 12-lead ECG run. The 12 leads are various combinations of 9 electrodes plus a ground. 4 of the electrodes are on the limbs, including the ground, and 6 are on the anterior chest. The 12-lead ECG is a bit sophisticated for our needs in this class, but it is good to know how this data comes about for future reference. Let's take a look now at an ECG tracing of one cardiac cycle. Remember, you are looking at a composite of all of the electrical activity of the heart. You will not see any mechanical activity on an ECG tracing. When you look at a trace, you will notice positive and negative deflections. I will explain later on why some deflections are positive and why others are negative. Normally, electrical activity in the heart begins in the SA node. And from the SA node, the depolarization spreads throughout the atria. And this is seen on the ECG as the first wave, and it's called the P wave. Depolarization reaches the AV nodes very quickly, but it gets delayed there by about 1/10 of a second. Then the depolarization moves through the conduction system into the ventricular myocardium. This is ventricular depolarization and is seen as the QRS complex. The time from the beginning of atrial depolarization to the beginning of ventricular depolarization is known as the PR, or in this case the PQ interval, because there is a visible Q wave. The last electrical event that is visible on the ECG is the T wave, and this is ventricular repolarization. The time that it takes from the beginning of ventricular depolarization through ventricular repolarization is called the QT interval. And the time in between the end of ventricular depolarization and the beginning of ventricular repolarization is the ST segment. And this is the time that the ventricles are maximally contracted. But there is no activity on the ECG. Let's take a look at a real Ecg trace, and let's borrow this one from your textbook. You want to develop a programmed approach when looking at any type of diagnostic data. For the Ecg strip, I'll suggest a simple approach which you can expand on later on when you learn how to identify pathologies, or you may want to experiment and design your own approach. Before you get started, if it's hard to tell where the large boxes are, spend a little bit of time figuring out where they are. Now here we go. I've got one box outlined and I can follow the rest from here. Alright, so let's start this process of analysis. Now this strip is showing 6 full cardiac cycles, so we will focus on those. And I'll give you the 3 most important things to look at to start off. The first thing you want to do is look at each group of waves for each cardiac cycle and see if there are 3 waves for each. So we're going to start all the way to the left with the first full cardiac cycle, and we're going to find the P wave, QRS, and the T there. So then the next set, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3. So each cardiac cycle has 3 waves. And so you might have missing waves or you might have extra waves, so you want to take note. Then you want to take a look at the intervals and segments and see if their timing is consistent through each cycle or if they are variable. And you want to take special note of the ST segment to see if it is flat or if it's elevated or depressed. And the third thing that you want to determine is the heart rate, and there are a number of shortcuts to determine this, and I'm going to show you a couple of them. The first shortcut is my favorite. It gives you a quick and easy way to estimate heart rate. But remember, this is just an estimation, and you have to have a stable heart rate to be able to use it. So first we want to find the interval between 2 R waves. So I guess this one right in the center will work for us. This is actually a really good one to use because the left QRS complex sits right on the edge of a box. Now that I've outlined this box, it's easy to see that there are 1, 2, 3.5 boxes to the next R wave. And so I can estimate that the heart rate is somewhere between 100 and 75, actually about midway between those two at around 87, 88 beats per minute. The way this is done is that each box is 0.2 seconds long. And if there are 3.5 boxes between each beat, then there's 0.7 seconds between each beat. If we take 60 seconds and divide it by 0.70, then we get around 86 beats per minute. And that involved a whole bunch of math. And when you are working quickly and all you need is an estimation, you can work a little bit faster, and here's how you do it. If the R waves are 1 box width apart, then the heart rate is 300. 2 box widths and the heart rate is 150. 3, the heart rate is 100. 4, the heart rate is 75. And 5 box widths apart, the heart rate is 60. So my estimate was that these R waves were about 3.5 boxes apart, and that's how I ended up with an estimate somewhere between 100 and 75, around 87. The other thing that we could do is that we can memorize that an RR interval of 0.8 is 75 beats per minute and an RR interval of 0.6 is 100 beats per minute, and we're at a 0.7, so we fall somewhere in between those two. That gives you a programmed approach to taking a look at ECGs, and I'm hoping that this gets you off on the right foot. So I want to do a couple more things with you in this video. The first one is to take a look at this picture which couples the conduction activity in the heart along with the corresponding ECG findings. So first thing to look at with this picture is the key in the upper left hand corner. The wave of depolarization is going to be in red and the wave of repolarization will be in green. And it's kind of important to know in what direction these will move. And so let's start in box number 1, and we see the wave of depolarization in the atria, and we see the P wave show up. Now, pretty soon after the P wave shows up, the atria are going to contract, but you're not going to see that on the ECG. In the second box, we see that little bit of delay there that is happening at the AV node, and then we have ventricular depolarization beginning. So we've got the Q wave, we've got the R, and then in box number 4, we see the S wave. In box 4, we see that ST segment where the ventricles are contracting, and then in box 5, we see the beginning of ventricular repolarization and the T wave. Something of great interest to note here on this picture, which is why I chose this picture to show you, is if we compare box 3 and box 5. In box 3 we're looking at ventricular depolarization, and the direction of movement of the depolarization, which is the sum total of all the action potentials in the ventricle, is downward toward the apex. Whereas with the ventricular repolarization shown in box 5, it is in the opposite direction. So repolarization starts in the apex and moves upward superiorly. So the first cardiac muscles to depolarize are going to be the last ones to repolarize. So why is this important to us when we're looking at ECGs? The direction of the current or the wave of depolarization or repolarization is going to determine whether or not we see a positive or a negative deflection. So let's go back to one of our first pictures and recall what was talked about in the beginning of the video. So let's take a look at our lead 2 picture one more time. Recall that the positive electrode is on the left ankle and the negative electrode is on the right wrist. If we take a look at the arrow in the center, the mean axis of ventricular depolarization is downward to the left. And so I explained that lead 2, it runs pretty parallel to the mean axis of ventricular depolarization. If we look at this arrow, we see a positive pole and a negative pole. What this is actually showing you is that the wave of depolarization, which really is a positive wave, is moving from superior to inferior and from right to left. This positive wave is going to be seen by the positive electrode, and this is going to give us a positive deflection. So the repolarization wave is the opposite to the depolarization wave. It's a negative wave. And so if we just switch the poles on the arrow, we would have the negative down at the bottom and the positive up on top, we would expect to see a negative deflection. But that's not the case in the lead 2 Ecg trace. We actually see a positive T wave. So why is that? Well, that's where box 5 in our previous picture comes in. So ventricular repolarization occurs in the opposite direction. So it's going from inferior to superior and from left to right. So we need to turn our arrow around in the opposite direction, and now the positive electrode is still seeing positive, and that's why we get the positive deflection. I sure hope that this clears up any confusion you may have had regarding ECGs and the conduction system of the heart. See you next time.